Okay. Hey, everybody. I'm about a minute early. I just want to make sure everything is working okay. On my end, it looks like it is. Hallelujah. So we'll just go ahead and get started. For those of you who don't know who I am, it's been a couple of weeks, maybe even months since I've been doing this. I've been too darn busy with work, but I'm getting back on track. And so we'll be doing these every week and hopefully a couple of times a week in order to help kind of spread the word. And so my name is Lindsay Venn. I am a physician assistant and registered dietitian. I'm also a founding member of the Society of Metabolic Health Practitioners. And it is my passion in life to help people understand insulin resistance and metabolic disease. And so today we're going to touch on the hot topic of diabetes and what it is. Tonight's going to be about what is diabetes and where does it come from and what is the physiology behind it. And then tomorrow night is actually going to be how to reverse it. And it's definitely something that you can do. So I'm going to start to share my screen. Give me 2 seconds. Um, Share. Just takes a second to come up and hopefully everybody can hear me okay. I'll turn up my volume. So good. Here we go. So like I said, the presentation tonight is all about diabetes and what is it? And because a lot of people think it is this chronic, progressive disease that they're just fated to have because mom or dad had it or grandma or grandpa had it. And I'm going to try to prove that wrong tonight. And so, and by the way, please feel free to put in the chat any questions that you've got. I have a hard time seeing them during the presentation, but I'll definitely get to them when we're done. And so please feel free to put any messages or anything in there. And so first, this is where you can find me. I'm at Venn Integrative Medicine. If you want to book a personal consult, then go to my website, and that's an easy place to get connected if you feel like you want more individualized one-on-one care. And of course, the little disclaimer, I am not your doctor. This is not personalized medical advice. This is for education purposes only. So first of all, diabetes. When we hear the word diabetes, one of two things probably pops into your head. Type 1 diabetes, which is the kind that people typically get when they're a little bit younger, and then type 2 diabetes, which tends to plague most of us when we reach our middle ages or as we get older. And so, how do we know the difference? How do we understand what is actually diagnosed as diabetes? The first thing that we look at is your hemoglobin A1C. And that number is something that your doctor will measure. They usually start sometime between the ages of 30 and 40 at just checking these every year with your wellness exam. If you struggle with overweight or obesity, you'll probably have this blood level done sooner. Or if you have any history of things like gestational diabetes, it might be something that your doctor will check more frequently. And so as you can see on here, the diagnosis falls when your A1C crosses this line of 6.5. So 6.5 and above, you get labeled with diabetes. Or if you get a fasting glucose that is greater than 126, then they'll probably do more workup to determine if you truly have diabetes going on or not. And what is the difference between type 1 and type 2? And you'll see me abbreviate. I use T1DM or T2DM, depending on which one I'm talking about. But type 1 is an autoimmune disease, very commonly triggered by some kind of um, typically a virus, some kind of major infection or some kind of major stressor. And so that kind of pokes the bear of the autoimmunity of the pancreas, and that autoimmunity will actually attack those beta cells, which is where insulin is produced. And when someone doesn't have enough insulin, that's when they get diagnosed with this type 1. So a real big differentiator. Type 1 has low levels of insulin, where type 2 has high levels of insulin. So type 2 is actually a metabolic disease. This is something that develops over time from poor diet, poor activity, stress, a lot of different things. But this is where the pancreas is functioning just fine. It's actually making high levels, extra insulin, and it's the cells in the body that have the problem. The cells, which is every cell in the body, from your heart to your brain to your liver to your muscles to your fat, those cells become resistant to the effects of insulin, leading to type 2 diabetes. But I want to talk about how that happens over time. And so first, if I can hit the right button, it's really important that you understand what insulin is, because insulin, again, too much insulin is the primary driver of type 2 diabetes. And so what is insulin and why is this a problem? Well, first of all, it's a peptide hormone. Peptide's kind of a hot buzzword nowadays because of all of these new medications and supplements, I guess you could call them, that are coming out. But it is a peptide hormone that's made naturally in the body. It's made by the beta cells of the pancreas, and that's where our insulin actually comes from. Insulin should only be excreted when we've been fed. You know, if you've eaten something, you're probably going to be making some insulin. If you haven't eaten anything, your insulin levels will actually be quite low. But its job is to be excreted by the pancreas once you've been fed to deal with the sugar or glucose response that comes from it. A really important thing to know about insulin is that it is a growth hormone. It likes to make things grow and it likes to store stuff. And so it really looks at what we're doing with the energy we eat. And its goal is to put it into storage, which makes fat grow, but it can also make other things grow. Prostate hypertrophy, for example, is a good one. Fat growing more can be one. And actually cancer is a big one because there is more insulin receptors on our cancer cells than there are on normal cells. And so insulin wants you to store stuff and make it bigger. And so it's not necessarily what we want as we get older and we struggle with our weight. And so how does insulin actually work? And this is where I love this image. Excuse me. Where I want you to understand that if this image over here is a cell, every cell wall has this membrane along here that works to keep stuff in and to keep stuff out and to let stuff in. And so the way it works is insulin that's floating around in the bloodstream after we've eaten will enter into this receptor site, and this receptor site will trigger this cascade events that opens up this GLUT4 channel, which allows glucose to get into the cell. So I compare this very often. If this receptor site over here is like a lock, like what we've got going on over here, and insulin is the key that goes into the lock to make things work, that's the easiest way to give an example. And so insulin is the key that opens the door that will eventually allow glucose to get into the cell. Well, what happens if your cell is insulin resistant? And so again, back to the lock and key scenario, your lock is broken. Your lock is actually not working, and therefore the key cannot get in and let glucose in. And so even though we have lots of insulin and lots of glucose floating around in the bloodstream, if this lock over here is broken and insulin can't get into it, then glucose cannot get into the cell. And this is where we develop a lot of different problems. That key can't do its job, glucose can't get into the cell, and therefore it remains in the bloodstream. And if glucose remains in the bloodstream at higher concentrations, that's what leads to type 2 diabetes. So it's all has to do with that lock on that door not working or the cells being resistant to the effects of insulin. How common is it? It's super common. There's only 7% of us in the United States that don't have some form of insulin resistance. So there's 93% of us that are actually what we would consider to be metabolically sick in one way or another, or have some level of insulin resistance. And so chances are you or someone you know definitely has insulin resistance and potentially prediabetes or type 2 diabetes. And so how does this work? How do we get into type 2? Again, the cells are very, very, very resistant to insulin. So we have lots of insulin floating around in the bloodstream, and insulin cannot keep up with, at a certain point, it cannot keep up with the glucose. Your pancreas will work as hard as it possibly can and make more and more and more insulin. But eventually the pancreas poops out, and that's what I call it, pancreatic poop out. And the pancreas cannot make enough insulin or provide enough keys that will eventually work in that lock, and therefore glucose will continue to climb. And that's when the diagnosis of type 2 diabetes will occur. And so what is going to happen if you're going through the traditional medical path? What is your doctor going to do? Well, they're going to add medications because they're worried about that blood sugar. They're not worried about your insulin. They're only worried about your blood sugar. And so they're going to give you something to lower blood sugar. The most common first step is actually metformin. And many of you have heard of metformin. Glucophage is the other term for it that we've heard. And I'm going to go over these in detail. They might add sulfonylureas. That's kind of the next line for high blood sugar. The GLP-1s that have become so popular nowadays too, now they're becoming really more of a first or a second step. They might do a combination of these things, which is definitely an option to help get blood sugar down. And eventually, if they can't get your blood sugar down, they're actually going to give you more insulin by giving you insulin injections. And so let's talk a little bit more about this. So metformin itself is a fairly safe drug. It's been around for at least 100 years. It's been well tested and well studied. It is what we call a biguanide. That's the class of drug that it is. And it works by doing three different things. One, it's going to reduce your liver's glucose production. And so if the liver's making less glucose, there's going to be less glucose floating around in the bloodstream, helping to lower that glucose level. It's going to help improve with that lock. So the insulin sensitivity, or that broken lock, metformin actually works at the level of that lock and improves the sensitivity to the keys, allowing the glucose to get into the cell rather than staying in the bloodstream. And then last, it's going to decrease your intestinal glucose absorption. And so if you're absorbing less glucose, obviously you're going to have less glucose in the system. The effectiveness of it is quite minimal. I will watch people's blood sugars or A1Cs drop. Maybe the glucose will drop 10 points, or maybe the A1C will drop a 0.2 or a 0.3, but it's not overly effective when it comes to lowering blood sugars. And it does come with its own myriad of side effects, which are quite unpleasant. I would say at least 50% of the patients that I have on metformin do suffer from one, if not all of these, where they'll have the diarrhea, the nausea, and the different abdominal pain and cramping. And so metformin does come with its own negative side effects, even though it can help a bit with that insulin sensitivity. And I do want to point out here, this is one of the two that we'll talk about that does improve and work on insulin. And so that's why this is one of my more commonly gone to medications, because it's actually working on the root cause of insulin resistance. It's not just working to lower blood sugar. The sulfonylureas. So an example I put on here is glipizide, but there's glimepiride and glyburide. There's a bunch of them that all end in that kind of IDE term. So what does it do? Well, it's actually an insulin secretagogue. And this, in my opinion, is maybe not a good thing if you have insulin resistance. So it will work at the level of the pancreas and make your body make more insulin. But if we go back to those first couple of slides where we're talking about the fact that we've got lots and lots and lots of insulin floating around out here, is adding more really going to be that helpful? Well, in some people it is, and some people it's not, but we're actually going to be worsening the insulin resistance by having more keys in circulation. And so that's why I say here, does someone with insulin resistance really want more insulin? Probably not. The GLP-1 agonists. So I put Ozempic on here as an example, but there's Ozempic and Wegovy, Mounjaro, and Zepbound. They're similar but different when it comes to the tirzepatide versus the semaglutide. But what does it do? So it is a mimetic, or an agonist is the other word that we look for. You can see up here. It actually mimics the effects of GLP-1 hormone. And GLP-1 hormone is extremely beneficial in the body. We really like GLP-1 because of what it does. It's going to help lower glucagon, which helps to lower the amount of blood sugar that our liver is producing, this process called gluconeogenesis. This one too, like the metformin, will actually help improve your insulin sensitivity. It does delay gastric emptying, and it creates more satiety, so people are just eating less. And it has been shown to reduce cravings for sweet foods, which of course, if you're eating less sweet foods, less sugar, you're obviously going to have lower blood sugar. But these do come with their own host of problems. So it's definitely not my first go-to when it comes to trying to help someone with diabetes. And then last is the exogenous insulin. So exogenous means that we're giving it to ourselves from the outside. And so there's two different kinds of insulin that your doctor might give you. So there's a long-acting insulin, such as Lantus, it was a very common one, or there's short-acting insulin, which is something like Humalog or Novolin. Those two insulins are critical for someone who has type 1 diabetes. They absolutely need insulin because their body's not making any. And so very critical that this is part of a type 1 diabetics medical plan. But for someone with type 2, just like with the sulfonylureas, does someone with insulin resistance actually want more insulin? And again, my answer to that is no. And I oftentimes will liken this to alcoholism. And so it's like in the beginning. So insulin is like beer. At first, when you start drinking beer, it takes one beer to get you a buzz. Over time, it's going to take you 2 beers. After more time, it's going to take you 3 beers until you're up to a case of beer in order to get the same effect. Well, insulin is very similar. You know, you start out with a few molecules being effective and you're going to make more and more and more and more. But the answer for the beer drinker isn't, well, hey, just keep drinking more beer. It's going to get you the same effect if you just keep increasing the dose. We don't want to do that with insulin. We want to actually cut back on the beer. We're going to lower the tolerance or the resistance to the effects of the alcohol, and therefore that person will get the effect at a lower dose. Same with insulin. If we can lower the need for it by lowering the carbohydrates in the diet and some other lifestyle interventions, we actually will need less insulin in circulation, less opportunity for growth, less opportunity to develop type 2 diabetes. And so the key takeaway, and tonight's presentation is short, but short and sweet is kind of nice. Type 2 diabetes is 100% reversible. And I shouldn't say 100%, but 99.9% reversible. There's a few cases out there that I've seen where we had a hard time with this, but it is just simply insulin resistance on steroids. So if you can fix the insulin resistance, you can absolutely reverse the type 2 diabetes. And I've watched patients do this in a matter of just a couple of months. If they can be really strict with the things that we want them to do, which we'll talk about tomorrow, they 100% can reverse their insulin resistance or type 2 diabetes. So what are the 3 primary drivers? And this is just a little bit of a segue into tomorrow because I want you to have an idea of what we're going to talk about. The number 1 primary driver, of course, is our diet. And so if we're eating a high sugar, high refined carbohydrate diet, eating frequently, lots of little snacks, the diet is going to cause insulin resistance and then eventually lead to type 2 diabetes. But some other factors that can most certainly play a role would include stress and inflammation. The hard part with stress and inflammation is those are what we call harder levers to pull. You know, if you have a lever to pull or you have 3 levers to pull, which one is the easiest for most people? Most people can't completely eliminate stress. Or if they have an inflammatory condition, Crohn's disease, irritable bowel disease, autoimmune disease, sometimes those are a little bit harder of a lever to pull. But the diet piece, 100%, we can control what we put in our mouth and how frequently we do that. And so it can be a very, very strong, powerful tool on lowering insulin resistance and type 2 diabetes. So again, remember which lever you have control over, and let's start pulling on that one first. So for tomorrow, what I want to talk about tomorrow is how you're going to do this. How do you reverse insulin resistance and type 2 diabetes if you have it? How are you going to reduce medications and do that safely if you are currently on medications? And what are some additional tools to help? There's a variety of tools that I myself offer, or Insulin IQ offers, or other groups that can actually help quite a bit with insulin resistance and type 2 diabetes. Let me stop sharing my screen and I'll go to the chat and see if we have any questions. Again, I don't know if it's a good thing or a bad thing to say sorry for a short presentation, but sometimes it's a good thing because diabetes, honestly, is pretty darn straightforward. And if you can actually implement the things that we'll talk about tomorrow, you can make a really, really big difference. So let me get in here and see. And if you can actually, now you can just hear myself. If there's any comments in the chat. So Linda says hello. Bobby's asking, do we only get glucose from what we eat? Great question, Bobby. No. Glucose from what we eat is definitely the most important place that we get glucose from, but our body makes glucose. And that's why someone can go on a 0 carbohydrate diet and still have normal blood sugars. Our body has this lovely thing called gluconeogenesis, where it will make as much blood sugar as it needs. There are instances in people where I see this be overdone, and so they'll be fasting. I've seen people with a 3-day fast, nothing but water, come in with blood sugars in the 140s, 150s, even up as high as 200. They are making too much glucagon. And that glucagon that also comes from the pancreas, which is called our alpha cells, if that glucagon is inappropriately high, then they're going to be making way more glucose than what they should. And so then the goal is to work on getting that glucagon level down. And the best strategy I'm aware of for that is to boost that GLP-1 production, because it's a good inhibitor of glucagon production. So yeah, no, and we can get it from stress. I've watched a CGM, worn CGMs and watched them. There was one time I was skiing and I got in a bit of a puckering situation, and I watched my blood sugar, even though I hadn't eaten anything that day. I just hiked up the hill and my blood sugar ramped up to 180 from the stress that I was experiencing. So stress in itself can raise blood sugar. It's a very natural, normal response because our body's meant, if you're in a stressful situation, your body's going to say, push all that fuel out there so I can run from the tiger that's chasing me, or whatever that's causing that stress. The other thing that can raise cortisol or glucose, I guess I should mention, is cortisol. And so chronic stress, even if it's low grade, chronic stress can raise cortisol, which in turn will raise glucose as well. And so that's why stress is one of those major things that I mentioned. A little bit harder to control, a more difficult lever to pull, but definitely a cause for higher blood sugar without being related to food. So let's see here. I see a couple of people watching. Hi, Carla. And Linda's on here, but any other questions? I always feel like I get too far into the weeds. I was trying to remain a little bit more basic today just to help meet the needs of the general public. And so type 2 diabetes for sure is a real problem. They say about 50% of people now, adults, have type 2 diabetes. And a lot of it goes undiagnosed because you're only getting your labs done once a year, but it's a very, very common, very significant problem that you can work on and fix simply by changing your food. Hi, Ellen. Ellen says, if you don't have insulin resistance, no inflammation, eat virtually no carbs, and still are in the pre-diabetes range, could there be an issue with the pancreas that could be checked? Yes, we can definitely check glucagon. That is one. We do develop, just like you develop fatty liver, you can develop fatty pancreas. And if your pancreas is fatty from a history of previous insulin resistance, then those alpha cells that secrete the glucagon can definitely be a problem. You're a unique case, my friend Ellen. So let's see here. Lisa, I have the dawn effect in the morning. How can I stop it? Usually it comes down to normal by the afternoon, but I'm sure it's because I still have insulin resistance. So yeah, dawn phenomenon is very, very common, especially in people with type 2 diabetes. We see it all the time. And then some insulin resistance can experience it as well. There's definitely some things that you could try to help with dawn phenomenon. We do push a lot of intermittent fasting when it comes to helping lower blood sugar levels, but sometimes fasting first thing in the morning is not so great for dawn phenomenon. The cortisol response and why this occurs is because your body wants you to be able to get up and get going in the morning. And so cortisol will rise 3, 4, 5 a.m. And following that will be glucose will come up. Some people do that a little bit more than they should, but that cortisol rise is what causes the glucose to come up. If your body is worried that it's not going to get fed, if it's feeling stress from the fasting first thing in the morning, a really good strategy is to actually try to eat within about an hour of getting up in the morning. And then you'll see that dawn phenomenon correct itself. And the longer you do that, the better it will be. The dawn phenomenon, to an extent, to a greater extent of a level, will actually improve. And so for people like you, I know that you enjoy intermittent fasting as well. I often encourage people to either fast through lunch, so have breakfast and have dinner, or to fast through dinner. And that way that they're retraining the body to not do that dawn phenomenon quite to the same extent. And so for a lot of my patients, that's a good strategy. And then eventually the dawn phenomenon just goes away and you can go back to fasting through breakfast if that's your preference. Larissa, what kind of lab tests should be done for a fatty pancreas? That's a really good question. You can get an insulin level, get a glucagon level. You may also want to get an amylase and a lipase. Those levels will be elevated frequently when it comes to fatty pancreas going on. If those levels are high, then that could indicate fatty pancreas, or if those levels are really low, that could indicate fatty pancreas. We want them to be in the normal range, knowing that the pancreas then is working appropriately. So good questions. I like it. Any others? Something fatty for breakfast, Lisa asks. I usually fast until dinner. I would do a higher protein thing, to be honest with you, a protein and fat. So for example, scrambled eggs and bacon would be a really good option. Full fat cottage cheese and Greek yogurt is a go-to of mine. anything that's got a good protein and a good fat in it. Yes. So I would definitely try that for breakfast. And maybe Lisa, if you're only doing OMAD or one meal a day, that might be part of that dawn phenomenon, especially in postmenopausal or perimenopausal women. Our body doesn't like stress. And so it tends to kind of overcompensate. And so maybe even just, like I said, maybe just doing breakfast and dinner would be a big change and helpful. Ellen says, if those levels are high, what is the fix? So the fix for high glucagon would be the GLP-1, whether it be from using something like the Feel Great system to boost your own GLP-1 naturally, or to take a GLP-1, whether it be a pill form or an injectable form. That would, bring it down. But first get it checked, because if your glucagon is not high, then that's maybe not the problem. Though we can't always catch glucagon. It's just when you're checking it, at that one point in the day that tells you where it is, then it won't tell you what it's doing all day long. So I would try to check glucagon, get your labs done for glucagon when you're typically experiencing the higher blood sugars. So for Lisa, like first thing in the morning, or if your glucose stays high all day long, then you could check it pretty much at any time. Larissa, I missed the second one. Get insulin level, amylase and lipase. Oh, and glucagon. So GLUCAGON is the big one. And that's the primary driver of elevated blood sugar for no other reason that we can figure out. It's those higher glucagon levels. Bobby asks, why would it be suggested to not eat any dairy? So the theory behind it is, and if you go back to my YouTube channel, Bobby, I did one on inflammation. It was probably a couple of months ago. But the main driver that people will say don't eat dairy is because of their concern that there's an inflammatory response. The study that I cite in that presentation before talks about the fact that they did a meta-analysis on dairy in people, and they really showed there was no increased inflammation in most people unless there was actually a dairy sensitivity of sorts. If you have lactose intolerance, or if you have, just a true sensitivity to dairy, then that can lead to more inflammation. So what I recommend for people who are concerned that dairy might be a problem for them is to eliminate it for a period of time, typically 6 weeks or more, and then reintroduce it. And if you reintroduce it and you feel great, keep on eating dairy. I eat dairy every single day. And I actually have lactose intolerance, but it doesn't give me any kind of inflammatory symptoms. If you eliminate it for 6 weeks and then reintroduce it, and all of a sudden you're miserable, your joint pain comes back, your gut is a mess, whatever it might be, then maybe dairy is not for you. With dairy, we do recommend to get the lower lactose forms of dairy. And so things like hard cheeses, for example, full fat things, heavy cream is a low lactose type of food. And so it's the lactose that has all the sugar in it. And the sugar can worsen things, of course, by that. So don't get your, regular milk, regular yogurt, ice cream, anything with added sugar, of course. And then your really soft cheeses tend to be a higher lactose concentration as well. So good. So Larissa's asking, what kinds of things can be done for fatty pancreas? Sorry, I promise that's my last question. Don't worry about it. Fatty pancreas is reversed just like fatty liver is. And so really following the low carbohydrate diet, prioritizing your protein, doing some intermittent fasting. Again, if you're like Lisa and you need to not fast maybe in the morning, fast through lunch or fast through dinner instead. But anything that will reduce that visceral fat concentration will be helpful with fatty pancreas. And one thing you might think about getting is getting one of the bioelectric impedance scales. The Renpho is probably the cheapest. Hume has one. InBody is probably the best, but it's pretty pricey. And then just measuring that visceral fat and making sure that as you're losing weight, that the visceral fat concentration comes down. Because as that comes down, the fat in the pancreas and the liver will also come down. Very good. Anyone else before we hop off? Again, don't forget, tomorrow night, we're going to talk about all of these interventions, some extra tools that can help, the pros and cons of what they are and why you may or may not want to use them. Diet, exercise, lifestyle intervention, stress, inflammation, all of those topics will be covered tomorrow night. And if you didn't get a chance to watch this, they are on my YouTube channel, just Venn Integrative Medicine. You can go back and watch at any time. So awesome. So I don't think there's any more questions. So I'm going to hop off. Happy Monday, everybody. Again, I do intend to be doing these a lot more frequently, and we'd be doing what I can to get the word out and help support you all. So Ellen says, thank you. You're very welcome. Everybody else, have a really great night. Again, Venn Integrative Medicine or Insulin IQ, you can find me. Happy to help one-on-one if you need it. Oh, good. Larissa says, thank you. LaDonna. Hi, LaDonna and Bobby. So wonderful. Okay, everybody.